So my task today is to give you a lecture, short lecture, as a primer on traditional and the novel anticoagulants and keeping the patient in mind. So my talk is the introductory talk for the session this afternoon, and I'm bringing it to the basics so that we get all on the same page. And my focus as I put the slides together was really to think about the patient so that everyone really understands why we're doing what we're doing. So the talk is about anticoagulants. So my first question then is to try to define what is an anticoagulant. An anticoagulant is a drug that prevents unwanted blood clotting. There are good clots and there are bad clots. So sometimes with the unwanted ones, we have to treat with an anticoagulant. The use of an anticoagulant drug has reduced medical complications in a countless number of people and has allowed for life-saving medical procedures such as cardiac surgery. So if you think about it, such procedures like cardiac surgery could never ever take place if we did not have anticoagulants. What are the clinical uses of anticoagulants? For the most part, through the lectures you hear, through the NATF sessions, we talk about prevention or treatment of venous thrombosis. We're now talking more about atrial fibrillation. You've heard talks this morning, acute coronary syndrome as well, because they're also associated with thrombosis, unwanted blood clotting. But don't forget also about the interventional procedures and cardiac surgery and the like, where it's important and critical to have an anticoagulant in that setting so that the surgery can go on and be successful. And also hemodialysis is another area where anticoagulants are used. This slide just depicts what are blood clots. You saw some pictures this morning. Here are some more clots. These are from Chicago, so they're not from Boston, but they all look the same. Patients present with deep vein thrombosis, clots in the leg, the myocardial infarction, the heart attack where you have vessels in the heart that are have the unwanted blood clot, and then the famous pulmonary embolism that we do talk about quite a bit. Our teachings for thrombosis, what is thrombosis, how does it occur, go back to Professor Virchow from the late 1800s, who through autopsy learned a lot, and what he learned, we call today now the Virchow's triad, and it still holds true, the teachings that he had for us. And he came up with 3 factors that contribute to blood clotting. And he said there has to be something wrong, an injury to the blood vessel wall. So the endothelium we've heard about, Dr. Libby talked about this morning, and the whole blood vessel system throughout the body. There's some kind of an injury to that. There's also an alteration to the blood. And then the third part is the blood flow. So if you have stasis of blood, that's one component. But what we've learned now today, too, the 3 components hold true, but we need 2 of the 3 things to have a problem before we have the unwanted blood clot. But we thank Professor Virchow for his teachings. And if we can look further at the Virchow triad, here's a picture of a blood vessel, a nice normal blood vessel. And one of the teachings from Virchow was that there's an injury to the blood vessel, and that's where there's the initiation of this blood clot. So an injury to the vessel. Within the blood that's flowing here are blood cells, platelets. We heard this morning Dr. Deepak Bhatt gave us a good lecture on antiplatelet drugs, but these very small cells within the blood, these are red cells, white cells, and the tiny little platelets are there, all important for blood coagulation. And then the plasma that is also within the blood has many enzymes in it, and we'll talk about those as we talk about how do the anticoagulant drugs work. So this is a tube of blood that was drawn from a patient, and when we centrifuge it down, we spin it very fast. We can separate the red cells from the plasma, as shown here in a picture, and it's this plasma component that is going to be important for us as we continue our talk today. So when we talk about hemostasis, those 3 components we've been talking about in a normal situation, as we sit here with normal hemostasis, our blood is not clotting, everything is flowing well. If there is an imbalance, as shown here, an imbalance between our procoagulant components and our anticoagulant components that make up hemostasis, we either have that unwanted blood clotting or we can have bleeding. So it's always a balance. One side clotting, one side bleeding. Normally we're right in the middle. So the treatment options for thrombosis, if we do have that imbalance and there is unwanted blood clotting that does occur, the traditional anticoagulants that we have used for over 50 years include heparin, which is an intravenously given drug. The sister drug to heparin is the low molecular weight heparin given subcutaneously, and warfarin or Coumadin, which was the only oral anticoagulant that we had for all these years. Now today, you've been hearing talk about the new thrombin inhibitors and factor Xa inhibitors. So if you think back to the picture where I had the 3 components and I had the test tube with the blood plasma in it, some of the enzymes and components in that blood plasma are these, and these are the coagulation factors that work together to make a blood clot in the end, that fibrin clot, which is actually the structure of the thrombus. We have today the drugs that will affect different components of the blood enzymes. If we look at warfarin or Coumadin, you can see that several of the enzymes are affected when we take warfarin, and these enzymes are inhibited, so it doesn't allow this fibrin clot to form. And this, which the color is kind of funny on it, heparin, low molecular weight heparin, and the fondaparinux inhibit specifically factor Xa, and also thrombin by binding to a cofactor called antithrombin. So you can see this coagulation cascade, which is the enzyme component of your blood. This is the target for the traditional anticoagulants that we have had for many years, the heparins and the warfarin. If we look at heparin itself, it's actually a natural product that typically it's derived from pigs. It's a naturally occurring biological product extracted from tissues rich in mast cells. Typically, the porcine intestine is used, but as you heard from Dr. Farid this morning, sometimes bovine tissue is used as well. It is a very old drug. It was actually our first anticoagulant, developed in Toronto in 1937, 1939, Toronto and Stockholm. A lot of the work was done. Initially, it was discovered in 1917 by McLean, but the work to create it as a clinical use anticoagulant was in the 1930s. It's a very complex drug, and it could be an advantage and a disadvantage, but the advantage to this complexity, it's this mixture of these sugar units that make up heparin, give the heparin a lot of different components. And besides being an anticoagulant, when Dr. Libby was talking, I thought, well, if we look at heparin, it also has an anti-inflammatory component to it because of this multiplicity of structures that makes up the heparin molecule. So I think there's more to the picture for heparin than just being a pure anticoagulant. The heparin itself, which this is what we showed on the previous slide, has very long chains of these sugar units, medium-sized chains, and very tiny chains where you have the different saccharide sugar units linked to each other. There are ways you can cut these long chains of unfractionated heparin, the parent molecule, so that we only have medium and small molecular weight components. The sugar units are the same, the linear chains are the same, but we don't have any long chains for low molecular weight heparin. We just have the short chains. And by doing that, we have drugs called low molecular weight heparins that are useful given subcutaneously and very useful with some better properties than the parent molecule for prophylaxis. If we go to even smaller, so we don't even have low molecular weight, we have almost what you call an ultra-low molecular weight heparin with only 5 of these saccharide units linked together. We have the drug called fondaparinux or Arixtra, but you can see it's all derived from heparin. So we've got 3 different types of anticoagulants, but all derived from heparin itself. And because of the different molecular weights, they have different properties that we can use them in different clinical settings. So heparin, the parent molecule, has been replaced with these low molecular weight heparins and the fondaparinux for many indications because these newer formulations have less bleeding risk, improved pharmacologic responses, less risk of heparin-induced thrombocytopenia. However, heparin itself, the parent drug, remains the anticoagulant of choice for acute treatment of life-threatening thrombosis. So it's a very potent drug. It's a very useful drug for situations where somebody is close to death with heart attack, for example, or in cardiac surgery where there's a very strong activation of that coagulation system. Just a word on warfarin or Coumadin, the other traditional anticoagulant that we have used for a long time. Bleeding in cattle led to the discovery of dicumarol, which was a vitamin K antagonist. And that was extracted from fermenting or moldy sweet clover back to 1939. So what happened is that the cows in Wisconsin were bleeding to death. The farmers came to the Wisconsin Alumni Research Foundation and said, could you figure out why my cows are dying and help me? So they did find this dicumarol from the sweet clover that the cows were eating. This is sweet clover. It was getting moldy, and that's why they the dicumarol was present. But from all of that work, that discovery is how Coumadin or warfarin was discovered. And why is it called warfarin? Because it came from the Wisconsin Alumni Foundation. There's your warfarin. Back to 1948. So since 1951, warfarin has been used clinically in humans to treat thrombosis, the unwanted thrombosis. So heparin and warfarin do have advantages. They're highly effective. They're inexpensive. We do have assays in the laboratory in the hospital to monitor them, and the assays are also cheap and effective as well. Then we do have reversible agents if we have an overdose for whatever reason. And one important point is that we have many years of clinical experience, so we know how to use these drugs. They have disadvantages, but because we've learned over time how to use them, we've managed to get around a lot of the different problems. So here's a list of some of the problems that are associated with the heparins. They are injectable, so most patients don't want to inject themselves if they could take a pill. There can be pain, skin necrosis. It's a potential at the injection site of the drug. The response, the anticoagulant response is unpredictable, sometimes in some patients, and the risk of the allergy to heparin called heparin-induced thrombocytopenia does exist with the drugs. Warfarin, as you know, has a narrow therapeutic range, meaning that there's a high risk of bleeding, food and drug interactions, variable responses between patients, and because of that, it does require routine monitoring and periodically adjusting the dose of warfarin. And the other point, too, is it has a slow onset. So if you have a patient with thrombosis, you would give a heparin first because it is a fast onset, and then you transition the patient over to warfarin for long term. So it's a bit of a complex scenario, but again, with years of experience, we've learned how to do this. Now, today is a new era. We haven't been here since the beginning of the anticoagulant age until just now. And we have new anticoagulants that are target-oriented. So they don't affect a lot of the multiple sections of that coagulation cascade that I showed you. They only have one target. And they've also been developed specifically, now that we understand what causes thrombosis. The warfarin and the heparin were serendipity. It was just by accident that they were discovered, really, and by accident then someone had the idea to use them clinically. So beginning in 1999, there was a thrombin inhibitor, several thrombin inhibitors that were developed and brought into use. The FDA had approved them, and this was for use in patients with heparin-induced thrombocytopenia. They were at very high risk of unwanted thrombosis, could not have heparin, couldn't have a long onset of drug. They needed a fast, rapidly working anticoagulant. So the intravenous use thrombin inhibitors first came out in 1999. Now today is the next phase where we have more of these new oral anticoagulants that are target-oriented. They inhibit only factor Xa or thrombin. But these now are oral. So I have the new oral anticoagulants. And this just shows you specifically the factor Xa inhibitors only inhibit that one factor. They do nothing else in coagulation or hemostasis system. The thrombin inhibitors inhibit only that one thrombin enzyme. So just very briefly, dabigatran or Pradaxa is approved by the FDA. It was the first of the new oral anticoagulants since October of 2010, and approved for atrial fibrillation, stroke, systemic embolization in patients with the atrial fibrillation. So we have dabigatran. We have also Apixaban, which was the second of the new orals to be approved by the FDA in November of 2011. Again, prevention of stroke and systemic embolization, patients with the atrial fibrillation. But it has another indication of venous thromboembolism prophylaxis in hip and knee surgery patients. So that's what we have today. Apixaban is the third new oral anticoagulant. It is with the FDA right now, and they're expecting to have an approval decision sometime this year. We don't have it yet, but we're expecting sometime soon. And the clinical indication that they have submitted for is, again, prevention of stroke, systemic embolization in patients with atrial fibrillation. And I should mention that even though we have these three drugs that I talked about, with these indications, they have other studies ongoing and trying to get approval for other than just the atrial fibrillation indication. You saw a slide very similar to this from Dr. Goldhaber this morning, just to compare and contrast Warfarin, which is an oral anticoagulant, to our new oral anticoagulants, and they are different. So there are advantages and disadvantages to both sets. And we'll see over time where we still use Warfarin, where the new orals will find their home, depending on what the clinical situation is. My point, though, is that we still are learning how to use the new oral anticoagulants because everybody is new to them. There's a list of a few things here that I thought about to bring to your attention, but we've been talking about them throughout the day already. The new oral anticoagulants, it's because they have a very fast onset and fast offset, which is a good thing when you don't want the drug around. But if you do miss a dose, then there could be a chance that you don't have coverage of the anticoagulant for your thrombotic condition. And because of GI stress with some of the drugs and the increased cost, it might be more frequent that doses would be missed. Bleeding was talked about. Dr. Ansel brought that up this morning, especially in the elderly patients and those with renal impairment. So we need to understand better how to use the drug in these patient populations. We need to make sure if there are any drug or food supplement interactions with the new drugs, other medical conditions which may affect the way the drug is absorbed in the body, how it is metabolized in the body. And if there happen to be bleeding complications, because there is no antidote at this point in time, but many people are working on that to find an antidote and also to find laboratory tests to determine what the drug level is if it's needed. So there's a lot of work that's going on still and trying to understand how these drugs are to be used so that we have the full advantage of them. So the summary I have is that the anticoagulants have been used for more than 50 years with great success. We need to keep them. Heparins and warfarins will remain the standard of care for some time due to their advantages and knowing how to use them. However, the new anticoagulants are now available, and we'll have more. This is just the beginning, I believe, of this new phase of new anticoagulants, and they provide more options for the management of thrombosis. Although there are advantages to the new anticoagulants, they are not without risk. As with any anticoagulant, there's always a risk of bleeding if you have overdose or thrombosis if you underdose. And studies and experience are needed to learn how best to use them.
I was sitting there thinking about how great that talk was, and I was thinking about how I really could have used that talk about 10 years ago when I was finishing up medical school. You would have saved me a lot of gray hair. That was really fantastic. So, one of the barriers, since we're talking about barriers to patient care in the area of thrombosis, is that the field's changing so rapidly, and with all of these newer agents coming out, it's very hard to overcome the lack of knowledge that's out there, both in providers and patients. I was just wondering if you had any suggestions for all of us about resources that we might be able to use, even NATF website, but resources that we might be able to use to help educate ourselves about these drugs and the changes that happen very quickly.
That's an excellent question, because that's exactly where we're at right now. Is education is key, and it's education for clinicians, for the patients, for the caregivers, for everybody who's involved with this. So the NATF is really an excellent resource. I think that's probably one of the first things you should do is go to the NATF website. We do have a lot of educational material on there, and we keep it updated as much as we can. But another thing that comes to mind is the support groups. We have DVT PE support groups, and we just started one in Chicago after the success of Dr. Goldhaver's. So we just started one in Chicago, where I'm from, and in fact I'll be giving a similar talk to the patients who attend that, just to get them kind of familiar with some of the new things that are coming on, and keep the information coming as we learn.
I think that's great. I think the exchange of information is what we really need.